everyone for joining. We hope you enjoyed the music about a doctor prescribing love. We felt like that was a very appropriate way to open up this session. So welcome to Connect+Healthcare. Today we're going to be discussing healthcare's role in addressing social isolation and loneliness among patients. So my name is Kasley Killam. I'm the founder of Social Health Labs, where our mission is all about catalyzing innovative approaches to social well-being. And I co-lead this series with my colleague, Eddie.
Hi, everyone. My name is Eddie Garcia. Nice to see you all again. For those who have been here before, and those who are new, I'm the executive director of the Foundation for Social Connection, where we are dedicated to promoting evidence-based initiatives to reduce social isolation and loneliness. We're going to just jump right in here. So a few housekeeping items before we get started. Please note that we are recording this conversation intentionally, and we will make the recording available after the session. Please feel free to use the chat box to connect, ask questions, and share your thoughts throughout the day. And your questions will be gathered for the panel a little later on today. Also, for those of you who are interested in transcription services, please note that the live transcript item is on the menu bar, and you can choose show subtitles or view full transcript for those services. Please note that the Connect+Conversation series is centered around inclusivity, kindness, and respect, and we ask that you be mindful of these themes when engaging in today's discussion. Just a quick review of today's agenda. We will be doing a brief introductions around the concepts that we'd like to explore on social connection, followed by a panel discussion and audience Q&A. Again, we'd like to ask you to leave your questions for the panel in the chat. We'll then move into a breakout session and to small groups before coming back for some closing remarks and some additional discussion. So with that, we'll move into the introductions. Kathleen?
All right, wonderful. Thanks so much, Eddie. So if this is your first time joining the Connect+Conversation series, welcome. Thank you again. The goal of this series broadly is really to generate ideas and share learnings about how we can address social isolation and loneliness and improve people's social well-being through different sectors and through different lenses. So if you missed the past 4 sessions, you can certainly watch the recordings on our website, and we'll link to those in the chat. If we go to the next slide, so just to give a bit more context on this series, throughout these sessions, we're looking at this topic of addressing social isolation and loneliness as a public health issue through different levels, all the way up from society-wide down to the individual. And so today we're going to be focusing on that middle layer, which is really institutions, and specifically the role that healthcare systems, organizations, providers, and so on can support, ways that they can support isolated or lonely patients. So we're really looking forward to discussing this theme with all of you and with our fabulous panelists. So we're going to do a poll quickly. We'd love to get a sense of who's in the room, where you're joining us from, and what your role is within the healthcare ecosystem. So you'll see a poll pop up there. Feel free to select your answer. It's all anonymous, and in a moment we will share out the aggregate results. All right, so perfect. We'll share those results. Okay, interesting. So we've got some providers, some healthcare executives, some patients, but also a lot of people from other backgrounds. So that's really interesting to hear. Please feel free to share in the chat what it is that brings your interest to this topic today. We'd love to get a better sense of that. And thank you all for joining and for being interested in this very important issue. And with that, I'm going to pass it back over to Eddie to introduce our panelists for today.
Thanks, Kathleen. I'm very excited to get right into it. So first up, we have Dr. Carla Parasinotto. Carla is a professor of medicine in the Division of Geriatrics at UCSF and a leading researcher on solutions for social isolation and loneliness among older adults, and a leading researcher on the Foundation's Scientific Advisory Council. Thanks, Carla. It's great to have you here today. Next up, we have Lisbeth Brions-Roberts, who is the Chief Togetherness Officer at SCAN Health Plan. Lisbeth joins us where she has developed and scales programs that address social isolation and loneliness among patients, and is really a community leader and catalyst in her work at SCAN Health Plan. It's been great to connect with you, Lisbeth, and excited to have you here as well. Finally, we have Sarah DeSilvi. Sarah is a rural family nurse practitioner and director of clinical informatics at the Gravity Project, a national initiative to implement social prescribing in healthcare settings, and has become a quick friend of the foundation and the social health lab. So we're so excited to have Sarah here to be a part of the panel discussion. Okay, next, just a reminder that we'd love to have your questions presented for the panelists. So while Kathleen will be running through moderating the panel and the questions, please do drop your questions into the chat. I will be compiling those and we'll have a Q&A session toward the end of the panel so your questions can be answered. So with that, I'll turn it back over to you, Kathleen, to get us started.
Thanks so much, Eddie. Okay, so let's dive in. I'm so looking forward to hearing from all of you. So I'd love to start off, Carla, Elizabeth, and Sarah, with just getting a better sense of kind of the perspective that you're bringing to this topic and some of the work that you're doing in this space. So Carla, let's start off with you. We'd love to hear more about your research on social isolation and loneliness, and also as a physician yourself, how that perspective has informed your viewpoint on this.
Sure. Thanks so much for having me. And it's great to see some familiar faces and some new faces. So I'll start by saying that I'm an anthropologist by training from a public health background, and then went to medical school. And my interest in research in this topic really stemmed from my work as a clinician. First and foremost, I see myself as a clinician, someone who sees patients. I'm a geriatrician and palliative medicine physician, so see people in the latter half of their life or when they're dealing with serious illness. And as a trainee, I was realizing that there were many things that were affecting people's health that we aren't traditionally taught about in school. And that really is what led me down this path. And, particularly as we age, what many of my patients and what my own family members and I value is, how can I stay independent, but potentially still connected? And how do I maintain my cognition? And that's what led me to really start investigating this idea of loneliness, which, wasn't something that I was taught. But I thankfully have some amazing research mentors and started learning that actually through my research realized that even despite comorbidities and the things that we usually think about as risk factors for problems in our health, people who report being lonely, different than being alone, so you're subjectively lonely, have many worse health outcomes. So my research specifically found that if you report being lonely over a 6-year period, you have an increased risk of death and increased risk of functional decline. So that was a really big eye-opening for me, because again, in medical school and the traditional models are like, let's look at just, hypertension and blood pressure. Sorry, they're the same things. What are the other things that affect people's health? Smoking, and not at all focus on people's social connections. Yet as an anthropologist, I knew that if you're talking to people, you have to understand people in the context of their families, their communities, their lack of families, who's around them, because this can impact a whole bunch of things. So this is really what led me down this path and continues to be, frankly, what I see in practice. I can tell you, from the pandemic, the number of patients who I see who have had a decline in their physical health because they have been physically isolated from people, doing less, potentially lonely also. I mean, it's magnitudes of what, is happening to people, and it's still not being talked about enough.
Thank you so much, Carla. Thank you for joining today and for sharing more about that. Elizabeth, let's go over to you. Tell us a bit about your work as Chief Togetherness Officer at SCAN and kind of how you think about payers' role in addressing this issue.
Absolutely. Thanks for inviting me. I have to say that I'm a little starry-eyed seeing everybody on this panel. Carla, I have studied a lot of your work and I really appreciate what you're doing. And actually, a lot of what I do is research for SCAN to see what are the best practices that we could implement on our end. But as far as my work as a Chief Togetherness Officer, as Eddie said earlier, it's really to look throughout the organization and find any opportunity where we can increase socialization for our members, where we can get them socially integrated, where we can address loneliness. and create some programs. So right now we are in the process of, we have 2 different programs. One of them is just a friendly caller program, except that I don't say just because that's a very effective method or tool to address isolation and loneliness. But we're also incorporating the peer, like a peer component. So we, for many years, have been using our members, hiring them as employees to come in and make outreach calls, work in the community with our other members, help them with onboarding, help them understand how to access their benefits, how to advocate for themselves in the medical setting. And we've been very effective at that, and also getting our members to talk to their doctors about those uncomfortable topics like urinary incontinence and depression and physical activity and falls. So we've been successful in that. We decided that this, we needed to apply our learnings to this other space, which is, loneliness and social isolation. So our Friendly Caller program, although we do have some volunteers throughout the organization, throughout SCAN, that will be calling members, we're going to be relying on our senior members that are called peer advocates to make those outbound calls. The great thing about it, of course, is that they have that shared common experience, life course. They've kind of similar life course as them, and of course that makes them a little bit more open, and the members more open to hearing what they have to say. And it's been really wonderful. As far as SCAN's total responsibility, what we see, what we should be doing, of course, is as Carla said, this is a health issue. It needs to be addressed as an actual health issue. There are so many different, there's so much data that shows that anyone who is lonely and isolated, just doesn't do as well. And so we feel like if we address it, we believe that if we address that particular issue, that we will actually be able to improve our health outcomes. Some of the challenges, of course, are being as a payer, how we can spend our funds and that, but that's, we feel like a real responsibility to help reduce, both for our members and financially for us, actually.
Wonderful, thank you. And I'm sure we'll get more into that last point in a little bit. But first, Sarah, over to you now. Tell us a bit about your perspective as a rural family nurse practitioner, and as well as your work on the Gravity Project.
I'd be honored to, and I guess it's my pleasure to be here today. Some of you I know very well, some of you I'm sure are new friends. So the first part I think is actually really important. So I have the honor of being a deeply rural nurse practitioner on the border of Canada in Vermont. And so the first thing I'd say regarding the topic of social isolation and loneliness is that because I've had the privilege to learn with Eddie and Carla over the course of the last 9 months through the Gravity Project, which I'll describe very shortly, is really kind of making no assumptions. One of the things that we've seen very clearly is that many of our older individuals, although one might expect that they experience loneliness because of very few social connections, they're habituated to rural environments and rural patterns. And so it's been very interesting to talk to my older adults who are really quite content in their isolated environment on their small farm with very few contacts, and they're just doing quite fine, even though with the presence of very, very few social connections in their daily life. Like maybe they go to church once a month, maybe they don't, right? But it's the lack of dissonance between what the expectation is and what reality is. For those deeply, deeply rural folks that have been rural their whole life and the life of their grandparents before them, and disconnected from what I see regarding the younger populations that I take care of too. So I'm full spectrum family practice, right? So I see everything from newborn babies to little old dairy farmers and everything in between. So what we've seen very clearly, and I'm investigating very clearly, is the deep and kind of instantaneous experiences of loneliness, especially over the course of the last year in the pandemic with some of my younger populations, my adolescent kids who had virtual schooling, and the expectation is their primary identity is with social connections. Or even some of the, the sandwich generation parents who are like really have lost their primary like lateral support system because their bubble has really shrunk. And so it's just like, a mom and their kids in a room trying to work and trying to take care of virtual schooling and just like the madness of all of that. So I think my answer really is really trying to parse out the difference between social connection and loneliness from a rural perspective. There's just a lot of things to learn there, based on expectations and based on the effect of the pandemic over the last year. And then specifically regarding the Gravity Project, just going into what that does, and we'll talk a little bit more about it later.
No, it doesn't. I don't work out of there often at all.
Oh, let's just make sure everyone, if you're not
That's a shit show that it,
get you
that
to-
it is.
We'll take care of that. There you go.
So just regarding the Gravity Project, this is how I have the honor to know many of the individuals on the call and on the panel. The Gravity Project's objective is to build the data and data standards to address the social and behavioral and psychological determinants of health. So, you know, I think you just heard me tell a lot of patient stories. The way I describe the primacy of this work is imagine how complex it is to care for people every day and not be able to tell their stories because there isn't the language to name the thing. Right. So I can name all kinds of granularity and complexity within the classic, physiology, pneumonia, etiology, the causes of pneumonia, or the laterality of the break, but I can't describe someone's social condition. I can't name their social determinants of health. At least that was the case before the Gravity Project came around. So the objective is to build a language to name these things and to build the pathways for sharing information regarding them. So this is part of what the Gravity Project end result is encoded healthcare language to name the conditions that we see, including social connection, loneliness, lack of social support, and relationship quality and relationship strain. And then also the collated sets of information that one might need to do that well. So if you're trying to think of like, what are all the screeners I can use? Our experts have collated them for you. Or what diagnoses that would be appropriate, they're all there. So it's both things to say and the ease of saying them, and that's the mission of the Gravity Project.
Wonderful. Awesome. Thank you so much, Sarah. And thank you too for bringing the perspective of rural communities as well as youth, which I think are both really important to this conversation. So we're going to dive into all of this much deeper. And specifically, let's really kind of go into detail on some of these approaches. So Carla, to go back to you, right before the pandemic started, the National Academies of Sciences, Engineering, and Medicine published a report about different opportunities for the US healthcare system to work on isolation and loneliness. And you were one of the expert contributors to that report. So tell us a bit about kind of the top recommendations that it made as it pertains to how healthcare professionals can take action on this.
Sure. Thanks so much, Kathleen. And I would say that, when the National Academy of Sciences decided to take on this project, it really was a huge moment for those of us in the research community, but also those of us doing direct work on this topic, realizing that this was going to finally bring this to a national landscape. And already we've seen things start to transform because of that. So that's exciting. But there's actually 5 key recommendations that are very critical and important to what we're talking about here. The first one is really about developing the evidence base. Now, the evidence base is already there around health effects. And I see a question in the chat actually about that there's a lot of focus on physical health, but the Kevin asks about the behavioral impact. And absolutely, Kevin, I think we're starting to see more evidence on the effects on substance use, but interventions is a whole nother story, and I'll leave that to the side. But so where we are in terms of needing to develop an evidence base, what the National Academy said is we know about the health risk. Where we need the evidence is on interventions, on what we do about this. Everyone says they have a solution. I love you're so motivated to do that, but please show me the data, show me in real terms what that actually means. Stories are great, anecdotes are great, but that's not enough to push public policy and push payers forward. So that's one of the main things. The second part is translating research into healthcare practices. So that puts the onus back on us as researchers. Great. I show you that it makes an impact on health. Now it goes back to, again, like that means that the next step is we have to show if we have an intervention, it'll actually change health outcomes. That actually ties into one of the other recommendations, which is strengthening ties between the healthcare systems and community-based networks and resources. So that means for payers, also for community-based organizations, how do we join our resources, show that our interventions work on health outcomes, which means having access to payer data so that we can show, and claims data so we can say, hey, if you could participate in SCAN's program or whatever it is, that this actually makes a change in health outcomes. So that's where we're going next. Improving awareness is one of the other recommendations. That is why we are here. So thank you to you, Casley, and the rest of the Foundation for Social Connection for getting the word out. And then strengthening ongoing education and training. We have a long way to go. We're doing a lot of work, I think, at the grassroots level and out in the communities. Where we need more work is certainly with people working in health, whether that be medical, social work, a whole range of or education, frankly. So I'll stop
Wonderful.
there.
No, that's great, Carla. Thank you. And I think it sets the stage well for the fact that this is now something that's getting national recognition, and all of you are doing the hard work of putting it into action. And so one kind of theme that runs through this is this idea of social prescribing. And I want to make sure we introduce this concept early for those joining in who may not be familiar. And maybe, Sarah, we can start with you on this to share a bit about what this is, what is social prescribing, and how is the Gravity Project approaching it?
Yeah, no, it was actually, I'd love to, and it's kind of hard not to jump. So Carla and I talk often, so it's kind of hard to jump right in and be like, oh, and, right?
Everyone feel free to jump in, Elizabeth.
I know. There are many different terms to describe what happens within the addressing social needs and social risks within clinical settings and behavioral needs and behavioral risks, right? So the idea is that it is social prescribing is the term that occupies the gap between where classic pharmaceuticals or therapies leave off, and all of the interventions that are required to address what we see affecting the health of the people we care for take over, right? So I'm cautious to use just the term social prescribing, because all of the things that happen outside of the clinical space are really the heft of everything of where our patients are. Like, we see them for a fraction of the amount of time that that they exist in their lives. But yeah, so that is that. It's basically, if you can imagine the clinical and pharmaceutical and therapeutic stopping here, and then social prescribing takes over. So the way that there's two things I want to build off of what Carla said in that concept. So number one is the idea of the evidence, right? So if there was another reason for why the Gravity Project exists and why we have experts like Eddie and Carla helping us in this work, is it's very difficult to establish evidence for interventions without the data on the interventions. And so if you do not have the terminology to document the interventions, you can't do the broad studies that we know we need to do to move the dial. This is across all of the social determinants of health. It's the same argument for food insecurity, same one for transportation insecurity, same one for housing. The same thing remains true. So the terminology regarding what we do is really critical for moving the dial on the research. And it's also critical for doing for what Carla was mentioning regarding the sharing care across clinical and social settings. So we don't just need to define the thing we're doing. We need to define it in ways that, regardless of where we are, I'm in clinic, you're at the area agency on aging, you're at home health, you're at the community-based organization. How do I say what I did and what I want and what's happening, and have everyone in the room understand it, right? So there's no confusion. So that's part of what we work on as well. Toward that aim, what we do with the Gravity Project with the experts in the room is develop terminology for all of the best evidence-based and policy-aligned interventions for social isolation, loneliness, and lack of social support, so that those terms exist, so we can define them for clinical care, can define them for research, and can share them across clinical and social settings in order to enrich not just people's lives, but also the data regarding what to do next.
Wonderful.
All right. I hope there was a good answer.
That was great. Thank you, Sarah. Thank you. And I think I saw someone in the chat saying that they're from the UK, and I know the UK has really kind of led the way in many ways with regards to social prescribing. This idea of, doctors being able to screen for loneliness and other factors in their appointments, and then be able to link individuals to resources in the community for social engagement and other things like that. And so it's great to have people from the UK joining. We definitely have a lot to learn from them. So Elizabeth, I'd love for you to jump in now too, and kind of share more in detail about the work that you're doing in this. And I think what's important is that first, we all have to kind of recognize that this is an issue, prioritize it within the healthcare system, and then, make it happen. So Elizabeth, how are you doing that? And obviously you've covered that first step. So where do you go from there for organizations who might want to take those steps, but don't really know where to begin?
Well, I'm happy to say that we just got our 4.5 star rating for the 5th year in a row. And the reason that I say that, and it's important to us, it's because of the type of outreach and interventions that we have for our members. It's how we treat our members that I think really adds to that star rating. Also, we were in our area, we're definitely like #1 in member satisfaction for the same thing. And after the pandemic, or since the start of the pandemic, we've been doubling our efforts to do outreach to our members. So we see the value and the outcome directly in our star rating if we address this issue. So I think payers really should take a look at it from that perspective. Luckily, our CEO and our other executive leadership already see this as a health issue. And of course, we're encountering the same issue that Sarah just brought up about the language, making sure we have the correct language that is tied to codes that then will allow us to, advocate or to talk to policymakers about how we could invest Medicare and Medicaid dollars into this particular, area. So that's what we're really looking to do. So one of the things we want to do, to Carla's point about research and the data, we do have a lot of member data. We really do. In fact, we have been, health risk assessments is something that we're required to do for all of our special needs plan members. But we decided to expand that to all of our members, regardless of whether or not they're in a special needs plan. So all of our Medicare Advantage members, we have a 30 to 50% response rate. And those health risk assessments include questions about social determinants of health and including loneliness, isolation, resources that they may need. And so it would be, I think, a travesty if we didn't use that information, wisely. So actually, that's where we really started. We're looking at that data. We're looking at the members that are most at risk. So we know that they're lonely and socially isolated, and there are other, SDOH type of issues that we need to confront. So when designing our program, we knew that we had to have like a social worker specifically for this program, so that they would be able to provide some other services, therapeutic, caseworkers as well, to make sure that we could address the other SDOH issues, because if those aren't addressed, our loneliness, interventions aren't going to be as effective, right? So those are some of the, another thing that we're doing there. We want to share the data, so we want to add to the body of information. It's a little bit tricky, but of course, PHI and HIPAA and all of that. But what I'm hoping to do is to use all of those validated tools, all of those, everything we're creating is research-based. We're using the tools, the UCLA scale, PHQ-9. We're looking at some other scales to measure social engagement, social integration. And we want to, collect the data and make sure that we share that outside of SCAN, so that we can help to show that these interventions are actually effective. We're not comfortable with just the anecdotal. We need to have the actual hard data. And the reason why we want to add to that body of data is definitely because we want, part of what we want to do is to, again, encourage the federal government to, include, funds for this particular issue through the Medicare dollars. And so at this point, they really won't fund us for that type of activity. So we, as a nonprofit organization, take all the dollars that, traditionally I think for a for-profit health plan, maybe going to, some of their investors and all of that. We actually invest that back into the community and back into these types of programs. So yeah, some of the, as I mentioned earlier, we have the Friendly Caller program, but before we started the health plan, we actually were already doing it through our Independence at Home arm, which is our community service arm. So SCAN Health Plan, we serve our members, but there are so many other people that have need that approach us. So Independence at Home, they're the ones that help the community, seniors at large, others that are not our members. And so they have been involved in trying to reduce social isolation. So we've taken like their models and implemented them as well in our health plan for our members. But we're investing a lot of our dollars into that. The dollars that we're allowed to by CMS on the administrative side, not on the health paying side. I think specifically what we're looking to do is our aim is to reduce social isolation in our members by 20%, according to the UCLA Lonely score, the 3-item UCLA loneliness scale. And we're also looking to look at our data, our utilization to see if there was any impact. Although we're not basing our funding on whether or not we track outcomes through utilization, because we think that the data, that the research shows enough. So we are just looking at specifically lowering, decreasing the sense of loneliness. That's really what, our position right now. So I think and I really feel, I don't know if I can gush about my job or anything, but I feel very blessed to be able to work in an organization that sees things that way, because I think a lot of other health payers are like, they need to know what's the return on investment, how much money they're going to get. And, that's still hard to measure. That's really still hard to measure.
I just want to, oh, sorry.
No, go ahead.
No, I was gonna, add to, as you're saying all this stuff, Lizbeth, about what SCAN's doing, one of the things that the National Academy of Sciences suggested is more partnerships, because it's fantastic if SCAN has all this data. As we all know, when we publish data, there's going to be people being like, I wonder what they really reported, and they report everything, versus having someone external be able to look at this. And this is one of the challenges about doing research and who's doing the research and what gets published. I think as much as we're able to show what works, it's actually really important to show what doesn't work. Mm-hmm. And I think that's greatly missing. I will say there's so much work, and I will apologize in advance for whoever I offend. There's a lot of telephone support programs. There's a lot of new apps. The literature for the evidence is really slim. And I think it's partly because we're putting, all telephone support in one category, but really what one telephone support program does is very different than another. And so how do we really get into the nuances and the details of all this to really show, and really being thoughtful about showing negative data? And I think, when we talk about social prescribing also, and I saw in the chat how it's taking off in the UK. Well, the UK has a single payer system, very different than here. I would love for us, to me, what social prescribing is not just me talking to my patients about this is what is going to work for you after a mutual conversation, but having some programs where there may be evidence where it can be paid for. But that's a long way off. And we also have to remember that social connection isn't just like going and connecting to a program and like shoving someone over there and being like, okay, this organization is going to now deal with this person's loneliness. For some people, the need for alleviate loneliness is a one-on-one connection. And so how do you go and move from that? I see a lot of charts in the chat, things in the chat about what it means to be a peer. So it's way too much to say, and I'm going to be quiet now and see what else, because Sarah wants to say something, I can tell.
Well, not only do I want to, Carla, because you know me, but also I want to try to tie some things together, because there's two different things I want to say. So one is in response to a comment in the chat regarding, I heard Sarah say that there's a collation of screening tools. Is this true? And the answer is yes. Right. So in the spring, the amazing subject matter experts, so Dr. Julianne Holt-Lunstead, Eddie Garcia, Carla, and then Matt Pentel from UCSF as well. I didn't use the doctor term there because you're Carla in this presentation, but
yes, perfect.
Okay, great. So we Gravity worked with this amazing team to collate best in class, or at least face and content valid tools for social connection, loneliness, and lack of social support, including alignment with what that outcome statement would be, like what tools would be good for social connection, what tools are good for loneliness, what tools are good for lack of social support. And that all is complete work that I will put into the chat as soon as my rural bandwidth for my internet allows me to have that page open. And then the other thing I wanted to state, building off of what Carla was stating, is part of what the Gravity Project does as well is really like clear definitions for things, right? So part of building terminology is not just creating the word, it's actually creating the term and saying, this is what we mean by blank, right? And these are representative programs, and creating there's like a taxonomy of definitions that aligns with the taxonomy of terms. So right at this moment, our Gravity Project is finishing up its interventions and goals work for social connection and isolation and loneliness. And that work is not quite ready for go live, but everything we did regarding screening and diagnoses is complete, and I will put the link in as soon as I'm able.
I just want to add, if I may, Kelsey.
Yeah, absolutely.
So I really appreciate hearing all of that, because I feel like we're definitely at SCAN on the right track. We are looking at making sure that we have a clear model for our interventions, and that we're keeping fidelity to that model, so that we can measure how successful or not successful. And we've really adopted a new kind of motto at SCAN, which is progress, not perfection, and also not to fear failure, because it's important. We can learn just as much from failed programs as we can from successful ones. And so I'm happy to say, Carla, that we are definitely looking at that and making sure that if something doesn't work, that we change it. We have a responsibility. We are serious about addressing loneliness. And I know I've used social isolation and loneliness kind of interchangeably, but really our focus is loneliness at this point. But we try to look at social isolation as a way to stratify our outreach to our members.
I think there was also a question in the chat about, I don't know where it was, but it's like, when does it become what amount do you need to do to have it being meaningful? And I'll say, without naming names, that I was recently talking to someone who's developing a program, and they said, well, we reduced loneliness during hospitalization. I'm like, is 3 days really meaningful? Like, when is it meaningful? Is 1 day less that I feel better important? When will that actually affect my health? And those are some of the questions that we need to understand. But it also means that I think it's also becoming trendy, unfortunately or fortunately, depending on how you look at it, to talk about this. So don't just, throw in loneliness measures just because it's trendy. Doing it because does it make sense? So, I think, again, the onus is on us as either, researchers, leaders, program developers, app developers, whatever you are, community organizations, to figure out when is it going to be most helpful for the people that I'm serving? When is it most meaningful? When is there a sustained response? I think what we've seen during the pandemic is that the longer it went on, the more worried we become. But in some of the research that I did during the pandemic, loneliness can be episodic, and there's chronic loneliness. So where are you on the trajectory, which is really hard in terms of measurement and research.
One of the things I'm hearing from all of you, and I love how this conversation has turned, so thank you each, is kind of that there needs to be greater partnership between all the programs and innovation that's going on in this space and the researchers. And that's something I see a lot, even with nonprofits outside of healthcare that I work with, who have creative solutions in their communities for reducing social isolation and loneliness, and would love to partner with academia more around this. So I guess my question is, how do we, or are there existing ways for those partnerships and collaborations to come together, so that when there are programs and researchers who would be a perfect fit to work together, how do we create that and really bring people together around this, so that we're sharing those insights and generating the data?
From SCAN's perspective, what we're trying to do is actually partner with universities and researchers and share the data. So we're looking at, different areas like how hearing affects, sense of loneliness, and just the impact it has on seniors' life, and trying to publish that data. And again, we're partnering with researchers to make sure that it's that it's been evaluated correctly, and that the information is correct. So I think that's one of the things that we're doing at SCAN.
I think, Kelsey, that's a really important point. And I would say, the Coalition to End Social Isolation and Loneliness and the Foundation, that's one of the things that I think that is the goal of our national work, is to really bring this together. I will say that the elephant in the room is often funding. So as a professor, I have to make my own salary. It's not like the University of California gives me my salary. That was a shock to my mom when she's like, wait, you're a doctor and you have to make your own salary. I'm like, that is correct. Yes, I do. But that's really hard, and research can be expensive. At the same time, there's a lot of ways to be creative in how to do this. But so these partnerships are really important, but they aren't free, which is what's really hard. But there are mechanisms out there, and it's again thinking about where do you start small, how do you start pilot projects, and even just getting proof of concept and like, okay, where do we start here, and then move on and make it into bigger projects. So.
I'm just going to say, it's hard. This is one that got us all talking, of course. So I'm going to say two things. And number one, I think is part of the mission of our work within, I keep on calling it the Gravity Project. It's really like a national initiative to be able to address for medical social care integration, which is understanding the complexity of people's lives and ensuring we have ways to communicate like within them. But part of the mission is ensuring that community-based organizations and nonprofits and the people who are actually offering the care have a real voice in the solutions that we're creating. So, you know, Carla's heard me say this, Eddie's heard me say this, but one of the things that we say within the Gravity Project is we might identify these things in clinical settings, but we solve them in communities. So really trying to make sure that community-based organizations and the community voice is part of whatever, you know, interoperability solution we create regarding sharing data. That voice from a consent and bandwidth and capacity standpoint is understood, that we make investments as a healthcare system in building capacity within our communities in order to address the things that we're identifying, because otherwise it's going to just keep on coming down the pike. And then I think that was the, I think I lost the other thought, but that was the biggie there. Oh, no, I remembered it. So the other thing I wanted to add is there, and I'm sure Elizabeth can speak to this, is that we really, like the origin of kind of my terminology work within the Gravity Project came from working within a value-based care setting. So I work and practice in Vermont, which is a very, very innovative ACO model across the whole state. And what we knew that we had to do was shift resources, stop chasing our tails, right? Stop chasing depression and suicidality and behavioral health outcomes, or even an uncontrolled A1C over here, if we're not addressing root causes, which are inequity, poverty, discrimination, bias, like loneliness, food insecurity, transportation insecurity, digital inequity. I saw that in the chat, right? So I do actually imagine futures where the documentation of the conditions that we know are driving outcomes within innovative payment models are actually able to shift resources from the healthcare system into the places where it actually gets fixed. That's my radical thought for the day.
Yeah, I'm going to add to that too, because I know the other elephant in the room is that SCAN, you know, health plans, they have money, right? So why aren't we, and you know, we are actually doing exactly what you just described, Sarah, is that we are not trying to address, well, we have dollars that we have to use towards those treatments of those different health conditions, but we're also taking just as much as we can from our admin dollars, our administrative dollars that we're and investing those in these programs to help, you know, so that's how we're able to reallocate. And we definitely understand the issue or the impact of inequities, and you know, just how that the effect of accumulation of that inequity through a lifetime can impact loneliness, you know, or risk for loneliness in later life. And so we are also, you know, that's one of the reasons why we want to make sure that we're addressing SDOH conditions, situation, you know, issues. But we would love to, you know, continue to be able to kind of advocate at the policy level about, you know, increasing our ability to utilize actual Medicare dollars for this. It's kind of an interesting experience. I know we did attempt to create some benefits that you know, were specifically to deal with social isolation, and it was a challenge. So what we were actually able to create is and is going to be covered by benefit dollars as part of our plans are we have like the our health tech line, which is like an IT line that helps our members learn how to use their tablets or devices, computers. And then we also have Health Tech Plus, where we will be sending technicians out to our members' homes if they would like some one-on-one you know, assistance, because we know that that's going to reduce that digital divide as part of that, you know, issue created by inequity. We are going to have learning communities where the purpose of it is to bring people together in groups of like-minded people. They have similar interests, synchronous, asynchronous groups, but some of them will have therapeutic kind of a purpose, and others will just be, again, interest. So we're trying to move our dollars, but if we all partner and can kind of really demonstrate the how it affects health, then we can certainly do more in that space.
I think it's so fantastic, Elizabeth. Sorry, what you're like, just that the digital health, addressing that. I mean, in our practice at UCSF of seeing homebound older adults, we were able to get about 80% of our adults on telehealth. Not that they wanted to, but we kind of had to during the pandemic, which is also interesting what we're seeing. But it really was so intensive. It's actually like having hands-on work. So it's so amazing. And I'm a skeptic, but I'm hopeful that we'll see change with these ongoing conversations, because it is astounding to me what we are willing to pay for some drugs with limited effectiveness for people that have terminal diagnoses, who have limited life expectancies, but we don't actually pay for and focus on the things that matter to people, which is social connection and being connected to others. So.
Well, I'm kind of idealistic, so I will do everything in my power to, I'm personally very passionate about this, and I've experienced loneliness, episodic loneliness throughout my life, and so I really understand, and I worked with, in this field with seniors for about 20 years, and I've personally witnessed the impact that it has on a lot of older adults. So it's something that, I'm personally passionate about, so I'll do my best, Carla, to to advocate within the organization and within the system.
I do want to, it's hard not to add on to that. Yeah, I just want to support everything everyone just said, because I do want to state, because part of what we can do is get into this kind of vicious cycle regarding needing data to pay for things, and then but needing to pay for things in order to create the change to get the data. So you get into this little vicious wheel. But I do want to state that part of our colleagues in our work at the Gravity Project are CMS and CMI and the CDC. So the government itself is interested in this data, knowing how it drives outcomes, and even from a cost perspective, right? You're never going to address cost of care in the U.S. We have our famous thing is that we spend the most and have the worst outcomes, right? So when that's the case, you're never going to solve that sticky wicket until you start addressing root causes. So we are very grateful to have Center for Medicaid and Medicare Services at the table with us in our work.
Wonderful.
Fantastic.
Wow.
If no one has anything to say, thank God, Kathleen,
I love it. This is why we invited you all to speak today. I'm also going to invite Eddie to join the conversation, because he's been able to monitor the chat a little bit more than me. And so if there are questions from there to bring in, I'd love to do so. But I also want to tie back to something Elizabeth said, and that all of you have touched on. We've kind of mostly focused this conversation on older adults, but as Sarah mentioned earlier on, this is something that affects youth actually disproportionately. And so is the approach that healthcare should be taking to address isolation and loneliness the same with youth as it is with older adults, or do we need to be doing something different there?
I think definitely. I'll let you go.
No, you go first, Elizabeth, and now I'll chime in. I like being the chimer.
It's going to be a little bit more of my personal opinion. I actually, during the pandemic, was so very struck by the issues that were coming up, and social equality issues, and loneliness, the loneliness epidemic, that actually returned to school to work on gerontology, Master of Gerontology, and I'm focusing all of my research on isolation and loneliness. And a lot of what I'm seeing is that the interventions for youth should be, different but we need them, and there aren't enough. And so we should really be starting at like very young ages and providing this, support, so that we can make sure that they feel always socially connected. And this is going to lead to healthier older adults in the future. So it's my 2 cents.
I'll chime in from family medicine, because I do specialize in adolescent psych and trauma in my weird little way up here on the border. I think it's, again, I think there should be no assumptions that this is a problem of older adults first, right? It should always be the driver when you if there should be a deep investigation regarding experiences of loneliness and perceptions of being isolated whenever you're encountering anyone who's having any change in behaviors across the young adult spectrum, right? And I have two different thoughts regarding this. So one is, again, it's kind of the same one I made before. And again, I'm not a researcher in social isolation, social connection. I'm just a normal rural family practitioner. But I think one of the things that has been very helpful is to investigate positive aspects of of digital connectivity, right? So being really, because the moment you take a limited screen time perspective in a pandemic with adolescents who are barely trying to just keep their social circles together, and you say, oh, have you been on screen time for 2 hours or more? Like, you lose half the room, because they're like, listen, all I'm doing is holding on to my group of, queer authors across the US. And if you take that away from me, I have nothing, right? Or like, all I'm doing is like my ability to connect on the internet or through Snapchat or through Instagram or through whatever, through my multiplayer connection with my best friend from high school. It's all I got. Like, don't take that away from me, right? Mm-hmm. So I've been very, very careful within my practice to, again, make no assumptions regarding what's happening within social media and digital connectivity, and to investigate what the perceived benefits are for patients, for adolescent patients, especially within the last 2 years, right? And that's just my little, again, anecdotal, not an expert, but like, what are you finding there? Is it meeting your needs? How can we support you in that? What other tools do you need? What are your interests? How can I connect you, right? And that's been beneficial.
Wonderful. Well, thank you.
Anything that is through everything that we experience through our course of our lives is going to impact our future and everything. So I think you're right in addressing the things and that it's actually going to make a difference. What we're really facing, right, is structural lag. Right. And that's because we don't have, so in addition to addressing specifically loneliness or social isolation with children, we need to be able to create, more equity in, education, in the job opportunities. All of those things will actually also, influence whether or not somebody is at higher risk for being lonely. So
I forgot one thing. So I'm sorry, I just wanted to add on that, sorry, I can just go on forever. Carla's laughing. She knows.
I love it.
So just from a young adult perspective as well, affinity groups I find to be really important as well. And we didn't mention that yet. Like, so especially with identity seeking and identity forming, like, who am I, right? So it's also like, you can have an individual who's deeply socially around people all the time, but they're not connected to people who share the identity that they're finding themselves aligned with, whether it be like interest or sexuality or gender identity or ethnicity or anything, right? So a part of working with adolescent patients, and I get patients across the age spectrum, really is supporting addressing loneliness through ensuring connectivity with peers that share similar experiences with them. So that's part of what we do up here on the Canadian border in the middle of dairy country too.
So with a little bit of time in, you've all been wonderful panelists, and you've been reading the chat and answering questions as we've gone along. So I really do appreciate that. One thing that I would love to get from all of you from your individual perspectives is really around barriers to implementing this work. One, if you could talk about what do you see as the biggest barrier for your piece of the healthcare system in addressing this work, and how do we overcome that?
I think from a clinician perspective, clinicians, and maybe I'll speak specifically about physicians, but it's probably broader, are like huge skeptics, and they want to understand causality. And it's fascinating. Like, clinicians try to say that they're data driven, but really then everyone does their own little thing and ignore the data. So it's hilarious and upsetting at the same time. But I think one of the biggest barriers, for example, two biggest barriers for me, I'm primarily a primary care physician working in geriatrics. I have so many things I have to do to to comply by Medicare rules, even though it's not what actually matters about the care that I give, but I have to do it for documentation. Until that changes and our incentives change and we're aligned with what actually matters to patients, there's nothing going to change. That's the first thing. The second thing is we have to get past this idea that I can't ask something about it if I don't know what to do about it. That's just not helpful. There's a lot of things that I ask about my patient's health that I don't have an exact solution about. I ask about domestic violence. I ask about, language status, immigration status. I can't always help my patients that are in our country without papers, but it's still important for me to contextualize their health. So we need to get past this poor excuse about, well, I'm not going to ask about loneliness because I don't know what to do about it. That's just I will refrain from using expletives. That is just not okay. So those are the biggest barriers from my world.
Yeah, I would say in our world, I agree with that as being one of the barriers. And I think another barrier for us is just being able to how we utilize dollars. And but I guess the other piece that's actually kind of an interesting thing, I'm sure it's not going to come to as a surprise, but a lot of our members do not want to tell us that they're lonely. They don't want to share that they are depressed. And I think that they are definitely they think that's a weakness, some sort of character flaw. And so we have to figure out how to get our members to be comfortable, older adults be comfortable with sharing so that we can then provide the help that they need. So that's one of the problems we're experiencing.
I'm gonna not talk about terminology as a barrier this time because you've all heard me say that a million times. So I'm gonna speak from deeply rural Vermont, where my patients drive to the local gas station in order to be able to get enough bandwidth to have a telehealth appointment with me, right? Services spotty. And, it's just, so digital inequity, I'm going to just say is we can talk about all the digital solutions. I can talk about social media, but if you're literally only able to have bandwidth in one spot in your town, it's just a problem. So I think really structurally, given how interdependent people are digitally in this era, I think lack of broadband as public policy is a significant problem. Yes. And oh, sorry.
There's a bandwidth.
Yeah, you had a bandwidth issue there, Sarah.
Yeah, no, that's fine. I was echoing Carla's comment, digital inequity here. Yeah, absolutely. And I was just saying, yes.
Those are three fantastic areas that, I think that's the point of our discussions, is to highlight these issues so that they can be acted upon. One thing I think that you've all highlighted is the need for awareness and around these issues within the healthcare system. Could you talk about what awareness programs or trainings are being deployed now? If not, do they need to be within the healthcare sector? Anyone can jump on that.
I'll just say real quick that I'm really proud of my colleagues here at UCSF, that it's a slow way to start, but it's great in that in our division of geriatrics, we're actually trying to train all medical students in topics in geriatrics. But one of the modules around presenting a case is dealing with the topic of loneliness and isolation. So not only are we talking about the inequities that we see in aging and how we treat older adults, but specifically tackling that problem early on in medical school is great. So that's a start. And I will say that since I've finished my training, for the first time when I'm on service working in the hospital, I have my residents say, hey, I think this person's here because they're isolated. And I'm like, oh my God, it's amazing. The world is finally changing. And we can actually talk about okay, well, how would have this been different if this person had family at home? Could we avoid their hospitalization? I'm like, there is hope on the horizon, my friends. Long way to go, but to be recognized as something to be talked about during rounds is phenomenal.
That's amazing. Elizabeth, what about in the payer space or healthcare executives?
Well, in our space, I think we really do need to continue to increase awareness with the population that we serve. We need to make sure that we're socializing and reducing stigma around these issues, which I think we have to take a different approach than you would for maybe younger people. And so we definitely, I think the peer interaction is helping by, exposing or sharing, having a senior talk to another senior openly about things that are hard to talk about. I mean, I actually might have a team of about 43 different seniors that I supervise, and they all have very different backgrounds and belief systems, different political affiliations, but when we all talk together about these kinds of issues, they all come to an understanding. So they are, talking about it with an older adult between themselves actually does make a difference. So I think we need to continue to push that a little bit more. But then for the dollars, maybe communicating to other payers. I mean, as Carla said, people who are lonely are having longer hospital stays. That's a fact. Someone who is socially isolated is here in the US, they're going to pay about $1,600 more per person per year. A woman who is, isolated is going to pay more than we're going to pay more than $3,200 a year extra than someone who is not lonely. So I think we just need to keep sharing that information with other payers.
Agree. And then finally, Sarah, any trainings on the horizon around these new terminologies? Any thoughts on that?
Oh, yes. Yeah, I just have to stop building, you all. Yeah, we're almost done with this phase of build for the Gravity Project, which wraps up in about a month, close, because we're not just working on social isolation and social connection and loneliness, we're working on multiple domains at once. But yes, there will be trainings regarding how to implement the data elements that we have collated, and hopefully I want to let everybody know that eventually all of the terminology we create is available publicly in a place called the Value Set Authority Center. So if anyone ever wanted to go and just draw down the different codes and all the different things that are in those sets, they are there forever, curated by our team. So a deep thanks to everybody for helping us with developing those terms, and thanks for this time today.
Well, and a deep thanks to all of you on the panel and Kathleen for the wonderful discussion. I think we're going to turn it now over to our breakout session so we can continue this dialogue on a more intimate setting.
Absolutely. And we have a few announcements to share before we do. I know we're a couple minutes over the top of the hour. So thank you to everyone who's been able to stay. If you do need to hop off now, we totally understand. But if you're able to stay, we are going to do breakout sessions, as Eddie mentioned, where you'll have the opportunity to share your thoughts in more length on this topic and discuss what you might be doing in this space as well. But Eddie, I'll hand it over to you to share a few announcements before we go into those.
Thank you. So everyone, our next session will be Connect+ Technology, which will take place in November, and we will announce the speakers for this in the next week. We've simplified our registration process so you can sign up for it and all of our subsequent sessions in the series all at once using the form that we will link to in the chat now. Also, for any of you that would like to get involved, there are many ways for you to do that. One, please reach out to Kathleen and I and our team. We're happy to link you into with our speakers across the series, but also our ongoing work. I also encourage you to join the Commit to Connect program and the nationwide network of champions who are dedicated to ending social isolation and loneliness at the local, state, and national levels. Or get involved in the Togetherness Hub, which is a global community of people working in this space where they share and collaborate across the work. And we'll be sharing links to all of those things in the chat as well. And I think with that, we'll move right into the small groups.
Great, absolutely. Let's do it. So we have a few discussion prompts to spark conversation for you, but of course, these are going to be self-led, so feel free to take the discussion wherever you see fit. But if you'd like some guidance, we encourage you to introduce yourselves, to perhaps share what stood out today to you from today's discussion, and then really get action-oriented and think about how you can incorporate some of these insights into your healthcare setting, depending on your role or in your community, or how it's relevant in the work that you do. So with that, we will enter breakout rooms, enjoy, and we'll come back together as a group at the end to share back. All right, so we'd love to hear from you. Feel free to share in the chat, or you can also, we have a few minutes, so if you'd like to unmute and actually share out, we'd love to hear kind of what you learned today, what some of the takeaways were for you, and if this sparked any ideas for your work. Robin, can I put you on the spot? We're so happy to have you here.
Go right ahead. I was saying there were so many things that I could relate to, and hearing the panel. And, you know, the thing that it really stuck with me is what Carla was talking about, like one program doesn't always fit all. And, you know, every telephonic, and I really think that just like we're all unique individuals, that's the hard part of, you can't really cookie cut it. And that's one of the things I love, how we set people up with phone pals that are strangers. And we were talking about how talking to strangers, there's an article that just came out that says talking to strangers actually improves your health. But once you find that commonality, and I think that that's what you've got to keep striving for. We all connect in different ways. And, you know, myself, as Elizabeth was talking about her loneliness, I just relocated to a new community. And I am looking at ways to connect with people on my own self, and knowing that that's important, that we have to do. I'm going to take ballroom dancing, so hopefully meet people and doing something. But that's the thing that I took away from it. And I will say, now going almost 5 years of collecting data, it's messy. And no one, and like you said, how long do you got to sustain the improvement? 3 days? Does that make you less lonely? Or, you know, 2 years? I don't know. We see people that are doing really well and they get a new cancer diagnosis and then they digress right back to where they were before. So I think that just like in healthcare, things can change overnight. We just got to keep being creative, but not giving up, whether we make mistakes or it's not working the way we thought. Just keep plugging along. That's what I would say, especially for anyone who's thinking of starting out. 4 years ago, nobody else was doing the things that we're doing. And now I look, Kelsey, just look how far you guys have come in a short time. So.
Thank you, Robin. Would anyone else like to share too? Either in the chat or feel free to speak up if you'd like.
Well, I'll build up on what Robin was saying. Oh, I'm sorry.
No, go right ahead, Kevin.
Thank you, Amy. Robin, just real quick on like how long do we have to keep the connection going for life? This is, you know, you don't just exercise one time. You don't do 1 3-mile run or 1 45-minute walk or eat 1 bowl of vegetables or meditate 1 time and think, oh, I'm healthy now, right? And those are all mostly physical health related. So for our emotional health, our connection, this is something that has to be a lifelong endeavor. It's going to go in, you know, ebb and flow. People will come into your life for a certain period of time. Some longer than others, some have a greater impact than others. I think the people closest to us have the greatest impact on us. I think having a conversation with a stranger is a wonderful thing and it can feel amazing, but you know, how long does that last? An hour, a day, maybe 3 days? But when you get rejected or neglected or shamed or judged or degraded by a family member or a close friend or your boss at work or your teacher at school, those wounds, that pain, that trauma can last a lifetime. So this connection effort, it knows no age, it knows no demographic. It is from birth, 0, or you can even say before birth, but we'll just say from birth until you die. That's it. We need connection our whole lives, or else we feel the pain. And then we're going to forever try and ease that pain, typically with some kind of behavior. Drugs, alcohol, food, more work, more exercise. But it doesn't fill the hole of not having that person in your life, especially the one that matters most to you. So.
Thank you, Kevin. Beautifully said. Absolutely. I think we probably have just time for one more comment. Amy, if you wanted to go ahead, feel free.
Yeah, sure. I'll jump in. One of the members of my group brought up a really excellent point, which is that we need to be comparing people to their own best forms of connection. So not focusing on one standardized form in which individuals should be building their relationships, but asking them, does texting work best for you, or does calling work best for you, or what is the best mode for you? And not assuming that just because someone's not connecting in one form means they're disconnected. It might actually represent them being connected in other ways that are more suited for themselves.
Yeah, I think that's a really good point, and tailoring it for people's preferences is going to be really important there. Well, we are almost at the end of our time, so thank you so much to all of you who stuck around, and I hope that your conversations were interesting. We will share out a feedback survey both in the chat but also by email, and we'd love any feedback that you have to help make these sessions as wonderful as they can be. And I think we have one more slide. Thanking our partners. We've been really lucky to partner with Commit to Connect, as well as the AARP Foundation and the Administration for Community Living, who are leading Commit to Connect on this initiative. And we will send out more info about how you can get involved with their efforts later today.
Great. And I just want to thank everyone for participating. Again, look forward to having you also join us for Connect Tech in November. We'll be sending out more details about that. And again, stay connected. Great to see you all, and we'll talk to you next time.
Thanks, everyone.